then we can talk a little bit more generally about what we're doing with Luminopia, and then take your questions. So first question, we'll have a few questions to just prompt the discussion. So it's like, what types of patients do you consider for Luminopia? And you can consider sort of different variables, naive, treatment-naive patients versus, they've already been treated, strabismus patients, if they're post-surgery, or what size of strabismus, the severity of the amblyopia. We saw quite a variety there in those cases. What ages are you considering, et cetera? So maybe, yeah.
All right, so I'll kick off. So I think pertinent to mention, of course, that a lot of probably the prescribing I'm doing is a slight deviation from the strict FDA approval kind of guidelines. I have a practice that really does have a lot of patients that have had or undergone cataract surgery, or have had or undergone glaucoma surgery, and as a result, there's a little bit of a mixed mechanism to their amblyopia. I have a lot of patients that have, for that reason, patched from a very, very, very young age, and we've hit a ceiling. So to me, I have loved rolling out Luminopia in my practice, because I think these are really, really motivated parents who feel like they have put in so many patch hours and have gone through really tough surgeries, and then you present them with this sort of new, cool idea, and they are just 100% on board. And there have been times where I've really seen stagnation, and this has been something that has really moved patients forward in their visual acuity.
Yeah, I would agree. I offer this to treatment-naive patients, but most of my patients have already been patching or using atropine. And it's frustrating for the parents, it's frustrating for the kids. And once you introduce this, I have not had, every time I talk about this, the kid in the chair is like super excited, giving mom a thumbs up. And mom's like, I don't know if this is going to work, but we can try it. And compliance has been so much better, and it's a much easier discussion to have with families.
Is this still on? Okay, good. What about strabismus? So is there some magnitude of strabismus you'll think about before prescribing, and or if it's large, do you fix the strabismus first?
I think it's, personally, I think it's best to fix the strabismus first, because theoretically it should work with a small angle strab or no strab. But I've also prescribed it in kids where I think the largest is probably a 30 ET, and I don't think it's a binocular function at that point. Maybe it's glorified patching, as someone said yesterday, but it works, and they're still using it. And so as long as they're using something to help improve their vision, I don't see a downside to it.
I think I'd probably stick to smaller angles more within sort of our guidelines, but I definitely have employed it post-surgical when I've gotten small undercorrections or small overcorrections. A lot of times I have seen that those angles have actually changed and gotten better when there's been sort of a small difference in vision too.
Great. Yeah, so I do kind of the same as what you guys, I haven't prescribed it for larger angle strabismus. I mostly stuck to small angle, thinking that I do want this binocular mechanism to work so that it could be within some small degree. They could use their eyes together. And I do offer it for treatment naive and people who've been treated for a long time, whether it was a while ago or it was recently. And actually, I will use patching for larger angle strabismus, so I'll do that a little bit, then do the strabismus surgery, and then start Luminopia right after. I've done that a couple times already. All right, so next sort of prompt here is, well, how do you discuss this with your families?
When we talk about Luminopia, I explain that it's theoretically a different mechanism that's helping improve their vision. That it's only a limited amount of time compared to, like, say, patching. So I prescribe it for 1 hour a day, 6 days a week. I do tell them, if your kid's going to be on a screen and you want to give them extra screen time, please use Luminopia, not a regular tablet, because then they're actually working on their eyes at the same time, and because it's projected at distance, we don't have to worry about becoming more myopic. And kids are on screens all the time anyways, so I feel like it's just a better alternative to a traditional tablet.
Yeah, a lot of times I'll direct the parents to We have a lot of the pamphlets in our office, and there's a QRS code on there, and they can just take a photo, with their phone. It pulls up the Luminopia video. So I think that actually does the best sort of descriptor, instead of me trying to explain what dichoptic masking is and go into the nuance of binocular, suppression and et cetera. I just kind of show them the video. I say, this is a new technology. It works in a way a little different than patching. And, your child has patched before, they haven't patched before, but I think it's really cool. And then a lot of times I really target, especially for that like 6 and up crowd, a lot of my discussion to the child. And I really hype them up because, it's a VR headset and it's something their siblings won't have, and it's gonna make them more special. And I think that actually goes a long way towards getting the kid excited. And if the kid's excited about amblyopia treatment, 9 times out of 10, the parents are like, okay, sure.
Yeah.
I'll add that around the holidays, a lot of kids wanted a VR headset for Christmas. And so in November and December, there was a few moms that were like, we need to get this for Christmas for them. I was like, okay.
But I do tell them that it doesn't stream or do anything else that a VR headset does.
Right.
Because then they'll be disappointed.
Yeah. So I haven't really used the video much, but like I have my own little spiel, which is basically that, like I said before, it's a VR headset, although it's not really VR. And then I just explained to the parents that it makes them use both eyes together instead of just one, the way patching does. And I give us, if they're interested, I give them a little explanation actually about the suppression and the contrast and the masking. Some parents are interested in that detail, that's kind of basically it. I explained that, I think that we're going to talk about the prescribing in a second, so I'll hold that comment. But how do you set expectations with the parents related to actually getting the device and what the cost might be?
So this is one of the things, this can cost, depending on your insurer, anywhere from $49 to about $150 per month. So I'm very upfront with that because I don't want a cost surprise to kind of mislead a parent and have them kind of feel like they were led to believe this would be just as simple and straightforward maybe as patching. But I do always tell them that, this is a treatment we're trying. I want you back within, 3 months, because if it is not working, I don't want you continuing to pay this out-of-pocket cost. And I think it's a motivated population that will, if it's something that they want, then they usually are comfortable with it.
Mm.
And I've been surprised at the amount of people willing to go forth with this because, you think of a Medicaid population, which is predominantly what I see, and they're on limited income, but it's something that they still are willing to pay for to help their kids see better.
Yeah, I've had a similar experience. Cost hasn't been really a factor, and I think I explained to them that we're going to I send the prescription to the pharmacy, and then the pharmacy talks to their insurance company, which is what happens, and figures out what the cost might be. If there is a cost, there might not be a cost if it's covered. Even with, I think, a copay, the copay might be less than $50. I think $50 is, so let me back up. Luminopia, I think, has a arrangement where if it's not covered by insurance, they have sort of a program to improve access. So if it would be a Medicaid patient who, and correct me if I'm wrong on this, a Medicaid patient whose insurance won't pay for it, then the cost is $50 a month. And if it's a private insurer, then it's higher. And the highest that goes is, I think, $150 a month. So that's the highest it would cost. I stress to them, and I found that that isn't usually that much of an issue. And I think about 75% of families follow through with the prescription at least, I think from the Luminopia data. One thing I do stress to them is that they don't have to buy this thing, that they get it, they use it, then when they're done, they put it in the box that the pharmacy sent them and they send it back, because sometimes they think they have to buy it, and that creates a little confusion. We can answer more questions about all of this in the Q&A. Any pearls about the prescribing process or your experience with it? Any issues?
Well, I have to say, I think it was the prescribing that held me back from starting to use Luminopia. I just assumed it was going to be challenging to prescribe it. And as you alluded to, it's actually quite simple. I have Epic as well. I have all smart phrases to enter in all of the necessary data. You just specify the eye that you're treating and then send it to PhilRx. I made the mistake of not putting in refills on the first probable 10 to 15 patients I prescribed it on. So then I was getting monthly calls from PhilRx, but the people are lovely on the phone and they actually answer quite quickly. But I will say, do put in a refill because that was a mistake. And then I would also say, tell your parents that they're going to be getting a text message, and it doesn't necessarily say in that text message, this is a message about your child's luminopia. I think it uses verbiage about a prescription, and it can be a little bit vague. So some parents have kind of claimed that they haven't heard from the pharmacy or gotten anyone in touch with them, but then when you review what it should say, they actually did, they just ignored it.
Yeah, I don't have Epic. I had NextGen, and we just switched to ModMed last week. And I think having it in your EMR system linked to the diagnosis code is the best and easiest way to have it sent. All you really need is the diagnosis code, and that's how they program the VR headset. Aside from that, I think it's been really straightforward. They send you an email or a fax every week. PhilRx does, of all the patients that are currently on therapy. And so you can follow up if there's any issues with a patient not responding to text messages. I think after they get the text message, they get an email if they don't respond. And so PhilRx has been great about reaching out to patients. And as soon as it leaves my office, I don't have to take care of anything. And within a week, they get the headset. And some patients have had that text message as they're walking out the door that same day of the appointment. It's pretty quick.
Yeah, my experience has been the same, and I've heard actually really good feedback from parents about PhilRx, which is not part of Luminopia. It's just the online pharmacy that handles the prescriptions, and they're like really responsive if there's any questions or problems. So at least in my experience, the parents have had a good
I had a good experience calling them as well. So I would actually say it's been surprisingly streamlined.
Yeah. I do put down like 11 refills, or the max I can do, so I don't run into that
now
problem.
I do.
Yeah. I also put in the comments field, I put down if they've patched or used drops before, just because I don't know if that comment might help with insurance coverage at some point to say like, maxed on this or failed this before.
Yeah, you do want to put down, so you're prescribing it based on eye, so you'll write, Luminopia left eye, Luminopia right eye, and then, in the comments field, you want your ICD-10 code, and then, again, your prescribing number of hours a day and things like that.
Yeah, one just other little pearl related to that is that you're saying what the amblyopic eye is, unlike with atropine where you're putting it in the other eye.
Yes.
You specify the weaker eye, and then it does what it needs to do. All right. How do you guys approach follow-up? Like, when do you see them back? How often are you following them? And have you used the adherence portal that you can as a physician?
So I see kids back every 3 months, just like I would with patching. I do use the adherence portal, not on every patient, but particularly if they're not improving and it looks like, why are we using the device? I sign on there, and if they have less than 50% compliance, then we have a discussion about that. I sometimes think parents overestimate how much they're patching or how many times they're putting the drop in or how much the kids are using the headset. And so it's a good way to kind of keep them accountable, essentially. And some parents have kind of got the deer in headlights look like, oh, you actually know what we're doing. And then I think they're better next time.
I actually pull up the adherence portal sometimes with mostly older kids, because I think they think it's cool that I can somehow know exactly what they were doing. And sometimes I'll point out a day and I'll be like, what'd you do this week? You didn't use it much. And it becomes, I think, a lot more interactive in a way that kind of harkens back to if anyone brought in like patch calendars or things like that with their amblyopes. I just really feel like when you get the child to kind of engage with adherence, they start to be like, oh, Dr. Krause is watching me. And it really makes them have a little bit more fun with it.
Okay, great. And any other general feedback you've heard from the kids or the parents?
I told someone once that there was Bluey on there, and there is no Bluey. So do not make that mistake. There's Blue's Clues, but no Bluey. But I would say across the board, it's either a hit or it's not. I think if it doesn't work, you know quickly, like the child just doesn't ever put it on, and the parent tells you, and you just close that door because it's just they're too old, the amblyopia is just not treating. But the kids that do it, they really like it, and they really like that it's something new and different. So I hear a lot of positive feedback.
I also hear a lot of positives. I think the biggest negative is that YouTube's not on there and Disney Plus isn't on there. So, I mean, that might be something for the future, but right now that everyone else has been pretty happy with it.
Yeah. The other thing we do talk about is that it is Wi-Fi enabled, and it is a bit challenging to change the Wi-Fi that it's hooked up to. So most parents use it at home and they hook it up to their home Wi-Fi, but I think sometimes you might want to say be going to Starbucks and hook up to the Starbucks Wi-Fi. And it is a little bit cumbersome to do that. So it's just something that parents will tell me.
Okay, great. And just a fun question. So what's one thing you wish you had known about it, Luminopia, before you prescribed it to your very first patient?
I think you know mine. Refills and no bluey.
Okay.
I think I wish I would have known how easy it was to prescribe. I mean, I was really surprised when we first started it. I didn't think it was going to be so streamlined, and it really was.
I agree with that.
Yeah. When I saw this slide question, the first thing that popped into my head, which is the truth, I hope I can say this, is I was surprised that it really worked. So, I was surprised at how well it worked. It's definitely worked very well in more patients than it hasn't,